Assalamu alaikum. Today I will be with you to discuss a very important topic among female physical therapists, which is the abdominal and pelvic dysfunctions among postpartum women or ladies after delivery. We have three phases for the postpartum recovery or the postpartum healing. First phase اللي هي تكون immediate phase or initial phase اللي تكون immediately after delivery. هذا الفيز تقريبا تكون from 6 to 12 hours after delivery. During هذه الفيز عادة تكون اللي هي critical crisis اللي it needs urgent medical intervention, which is the excessive hemorrhage or bleeding, maybe the amniotic fluid embolism, the change in the blood pressure, which is the eclampsia, or any uterine complications like the uterine inversion. After that, the second phase, which is from 2 to 6 weeks, during this phase, major changes happen in the hormonal level, the metabolism level, and hemodynamic as well, and emotional status. Also, during this phase, عادة يكون اللي هو urogenital recovery, the recovery in the pelvis area, in the abdominal muscles, in the uterus itself. Uterus serial inversion, it regain the size and the shape like before the pregnancy. The third stage or final stage from 6 weeks up to 6 months. This is a very slow and gradual changes. في هذه السtage حيكون the lady or the woman will restore her normal body shape after delivery, and she will restore her muscle strength, her endurance, and her connective or soft tissue tone. Here we will talk about the mechanical features, the one it happens during pregnancy, and it will affect the postpartum. طيب during pregnancy إيش يصير؟ خلونا okay. First of all حيكون عندنا اللي هو forward head posture. Okay, this one. طيب during this phase حيكون عندنا اللي هو during pregnancy حيكون عندنا اللي هو forward head posture. مع forward head posture that will cause compensation in the thoracic spine, and it will increase the thoracic spine kyphosis, and it will cause the shoulder rotation as well during the third trimester when the breast is accumulated by the milk. That will increase the breast size, and it will cause the shoulders to be rotated anteriorly. كمان that will be compensated by increasing the rib cage of the anterior and posterior diameter rib cage by 6 centimeters تقريبا. اليوترس قاعد يزيد، فإيش قاعد يسوي؟ It's pushing the diaphragm up. The diaphragm will be pushed up or raised up by 4 centimeters. The thoracic rotation and thoracic mobility will be restricted. كثيرا نلاحظ pregnant women, they find some difficulty in turning around to the right or to the left to look to something behind her shoulder. It will be limited, the thoracic spine mobility, and the functional link between the abdominal and the pelvic floor muscle, it will be affected. Increase the intra-abdominal pressure will be not counteracted properly by the pelvic floor support if it's weak and if it's not trained properly before pregnancy. إذا ما كانت ready before pregnancy for these biomechanical changes. كمان حيزيد عندنا إيش؟ اللي هو anterior pelvic tilt. The angle, it will be increased, and the lordosis curvature will be increased as well. During the third trimester, the pelvic width, it will be increased by 15% تقريبا because of a release of hormone of relaxin, which increase the ligament elasticity to allow the baby to take its place in the pelvic inlet. That will affect on the descending angle, and it will increase the Q angle and the joint reaction force. Okay. As well, the pelvic width will be increased, the angle will be increased, the pelvic width size will be increased by 15%. That will increase the pelvis abduction moment, and the muscle activity, the higher muscle activity will be required to move this large trunk mass, the size of the trunk will be heavy on the pelvis and the lower extremities. It will, the higher muscle activity will be needed to move this large trunk mass over the lateral supporting leg. That will cause ايش اللي هو displacement of the body، راح يسبب الwaddling gait. We can see it very common among pregnant women who has a very wide pelvic width. Also, this increase in the pelvic width will increase the step width itself. فحنلاقي عندها wide base of support. She is trying to maintain her balance and her stability. كمان because of the decreased or the reduced in the thoracolumbar mobility اللي شرحناه، بالإضافة إلى decreased lumbopelvic mobility as well, that will decrease the stride length. The stride length will be shorter, and the imbalance between the anterior and posterior postural muscle, that will require higher muscle activity to perform her daily activities, and will increase the demand on these muscles to perform her activities. What's the most common postpartum dysfunctions? Let's start from the abdomen. We have the rectus, abdominus diastasis, and then we have the pelvic organ prolapse. And the pelvic girdle or the lumbopelvic dysfunctions could be low back pain, pelvic girdle pain, sacroiliac dysfunction, or pubic dysfunctions. And the incontinence, it could be urinary incontinence, could be fecal, and the fecal incontinence, it includes both flatal and fecal incontinence. And the voiding dysfunctions could be result from hormonal changes and habitual, the behaviors, the bad behaviors she developed it during pregnancy or postpartum. But it will not be linked directly to the biomechanical changes. But the other dysfunctions, it's linked to biomechanical changes. Here, let's talk about the pelvic floor function in beginning. The pelvic floor, the soft tissue itself, it's the water, okay? And the ligaments, and it's the suspending system, it's the passive system, it's like the ropes. Okay, and the pelvic organs is the ships. As a consequences of increase the intra-abdominal pressure during the pregnancy, and the pelvic floor, it's weak. The pelvic floor muscle here, it's weak. That will increase the strain on the ligament itself, and it might cause soft tissue damage or ligamentous damage. That might cause the pelvic floor dysfunctions. And here, regarding the pelvic floor muscle, we have not only one muscle, we have 3 layers of the muscle. Here we can see we have the first layer, which is the perineum layer, which is attached to the perineum. The second layer, which is the urogenital, the one connecting the urethra. by the vagina, the urogenital layer, and the third layer is the levator ini layer, which is the deepest or the largest and the most supporting muscle to the pelvic organs, the levator ini muscle. Okay. Let's talk about the first layer, the female perineum. The female perineum, it's starting from the pubic bone, the one on the left, this layers, the one on the left, starting from the pubic bone and attached to the perineal body, and perineal body is enforced by the central tendon. So we have here the ischial cavinosus muscle. Sorry. We have here the ischial cavinosus muscle. We have the bulbocavinosus muscle. This is the bulbocavinosus coming from the pubic bone and attached to the central tendon of the perineal body, and superficial transverse perineal muscle, and also the external inner sphincter is known as a part of the female perineum superficial layer. After that, the second layer, which is the urogenital diaphragm, the one connecting the urethra by the vagina, we have from superior or internal layer, we have the external urethral sphincter, and after that we have the compressor urethra. The compressor urethra, it comes like the loop. It comes from laterally from the perineal body, and it's surrounding the urethra, and it goes to the other side. And the uretrovaginalis muscle, it's inferior part of the urogenital diaphragm. It's like squeezing the urethra and vagina together, and the deep transverse perineal muscle here. The third layer, or the deepest layer, it's the pelvic diaphragm layer, which is the levator ini muscle. It's originated here from the tendinous arcus of the pelvic fascia. It comes from the pubic rami until the ischial tuberosity, and it's inserted. It comes from the both sides, right and left, but it comes this way, and it's inserted around the vagina, around the rectum and coccyx as well. So we have the anterior fibers, which is number one here, the pubovaginalis from the pubic to the vagina, and the intermediate layer we have the pubococcygeus attached to the starting from here, the anterior part of the tendinous arc of the pelvic fascia, which is attached to the pubic rami. So from its name, it's a pubococcygeus attached to the coccyx, and the puborectalis, it comes like the loop muscle as well. It's from the pubic, and it comes around the rectal, and the puborectalis muscle, it's the one who control the anorectal angle. The posterior part, or the third part, اللي هو number 3 اللي هو ileococcygeus. Number 4 اللي هي coccygeus muscle. From the ileum itself, from the part of the ileum which is attached with the ischial tuberosity to the coccyx itself. What's the function of the pelvic floor muscle? The normal function, it can voluntary and involuntary contract and relax. Contract to allow the continence, the passive continence phase, when the pelvic floor muscle in the normal resting tone, and when it's relaxed, when the pelvic floor muscle is relaxed voluntarily, it means it allows the stools to come out. It allows for evacuation, the stools, or micturition, urination, okay? Or even staying in the normal resting tone. The overactive, when the pelvic floor muscle cannot be relaxed and contracted all the time, even when you need it, you need the muscle to be relaxed, like during the defecation, during the urination, the muscle cannot be relaxed, and this overactive muscle, it always interfere with the sexual activity and with the chronic pelvic pain conditions, which are triggered by the physical or by psychosocial factors. The underactive muscle, when the pelvic floor muscle cannot be contracted when it's appropriate to contract. The underactive pelvic floor muscle happens always with a lot of factors. We will discuss it later now in this lecture. The underactive muscle, this is the one, the main cause or reason for the incontinence, for the pelvic organ prolapse, and maybe low back pain, a result from weak pelvic floor support. Not functioning when there is no action, zero muscle strength for the pelvic floor muscle, and this is not functioning could be happen due to the peduncle nerve injury, the damage or the trauma to the nerve who supply the pelvic floor muscle. So let's explore different types of dysfunctions might happen a result from the underactive pelvic floor muscle. The mechanism of dysfunctions could be muscle injury or soft tissue defect in soft tissue healing or recovery, or the peduncle nerve injury, which cause no palpable action. So the muscle injury and the soft tissue injury, it will cause widening in urogenital hiatus, and this is the one might causing the urinary incontinence, or even when there is damage or there is a trauma to the perineal area, and it goes backward to the sphincter itself, that might cause also the fecal or flated incontinence as well. Also, the muscle and the soft tissue injury or damage or defect that might cause the downward descent of the pelvic organs and associated with pelvic organ prolapse. The peduncle nerve injury, it might happen in 38% from operated vaginal delivery when there is damage or trauma to the pelvic floor area because of using the forceps or the vacuum or another instrument during vaginal delivery. So, the incontinence, it has many types. It has the stress urinary incontinence. It means the involuntary loss of urine with increase in intra-abdominal pressure, like playing your favorite sports, with physical activity, with laughing, with coughing or sneezing. That will increase the intra-abdominal pressure over the bladder. And if the second and the third layer of the pelvic floor, which is the urogenital layer or the pelvic floor, is weak, that might cause involuntary leakage of this urine. The urge urinary incontinence, it means the involuntary urine loss accompanied to urgency, which is the strong desire to void. In this case, the problem is mainly it's the oversensitivity of the bladder itself. The bladder wall or the detrusor muscle of the bladder is uninhibited. It's keep contracting all the time when it's when there is no need to contraction, or when it's not it's not full, completely full, and it doesn't give you this strong desire to urinate, but this urge incontinence happening. It means that the detrusor muscle, which is the bladder muscle, is unstable. Urge urinary incontinence, it might happen with urgency or frequency feeling only, and that could be a result from neurological condition to the bladder, or from the bad habit, the bad habits in our lifestyle. It might change the bladder and the connection between the bladder and the brain. But when with this urge feeling and with this urgency, urge urinary incontinence as well, the muscle could be involved with this condition. And the mixed urinary incontinence, it means the person will have the stress and urge incontinence as well together. That could be uninhibited bladder or over hypersensitive or overactivated bladder muscle, and as well weak pelvic floor muscle, which is not inhibiting the incontinence incidence. Okay, now اوكي الحين راح نتكلم عن ال pelvic organ prolapse. What does it mean pelvic organ prolapse? اللي هو ال bulge of part of the pelvic organs. And it might come out of vagina. طبعا it has different degrees and grades of the prolapse. So we have تقريبا 4 different types of prolapse. The first one is the anterior prolapse. The anterior prolapse, it happens when the anterior prolapse, it happens here. Okay, the anterior prolapse, it happens when the anterior vaginal wall between the bladder and between the vagina and uterus, it comes down this area. Okay. And the second one is the posterior vaginal wall prolapse, when the part of the rectum it comes down and it's interfering with the vaginal way and the lower part of the uterus, and also the uterus prolapse when the uterus itself it comes down through the vagina here. And the vaginal or vaultal prolapse in cases of the hysterectomy, which is the uterus removal, the vagina sometimes it's not supported properly, or there is weakness or laxity in the soft tissue which support the vagina, because of the main support system attached with the uterus is removed. So that might cause vaginal prolapse or vault prolapse. Okay. Okay. The pelvic organ prolapse itself, the symptoms نفسها related to other things. يعني the pelvic organ prolapse is related to the low back pain. It might cause discomfort and pain in the lumbar area and pelvis area, and it might worsen as they progress. It's also increase the discomfort with prolonged standing or مثلا with like using the stairs, going up and down, with being in a squat position. That will be discomfort to them, and it will get better when they are lying down. For this pelvic heaviness or this is vaginal pressure, it might interfere with the urination and with the evacuation. It might cause difficulty in emptying the bladder or the bowels completely and efficiently, and it causes also discomfort during the intercourse. فالpelvic organ prolapse itself يعني بغض النظر ان هي it's a condition or a complaint بحد ذاتها، لكن it's interfere with other things in life or other things with lumpopelvic conditions or complaints, and it could interfere with the quality of life. طيب بعد ما حكينا عن البلفس, now we want to go for the abdominal tissue and for the abdominal wall. The rectus abdominis diastasis. The diastasis is defined as the increase in the distance or the space between the interrecti abdominal muscles اللي هو stretching في اللاينة alba area, or diagnosed as diastasis when the widening is more than 2.7 centimeter. 2.7 centimeter يعني around 3 fingers تقريبا 2 to 3 fingers at the level of umbilicus. It could be It could be at 3 levels: الupper part والmiddle part والlower part. الupper part اللي هو above الumbilicus at the first pack. الsecond part اللي هو هنا زي ما انتم شايفين هنا could be in the upper part اللي هو and the first pack of the rectus abdominis, the second one at the level of umbilicus, and the third one below it. Diastasis could interfere with the posture, with the breathing, and the lumbar and pelvis condition or stability. ايش risk factors? The risk factors is the multiparity and grand multiparity. يعني 3 and above deliveries. The child care responsibilities like carrying the child, يعني putting a lot of strain and increasing the intra-abdominal pressure in the postpartum recovery stages, and also the maternal age. All these risk factors to increase the severity and the duration of having the diastasis rectus abdominis in the postpartum phase. And this is the confirmed risk factors. And there is conflict evidence linking the diastasis with the weight gain, with any increase in the weight during pregnancy, or higher body mass. And also the diastasis it's not associated with low back pain. No studies supporting that the diastasis could causing low back pain, but it increases the lumbo-pelvic vulnerability and the risk of having lumbo-pelvic defect or dysfunction later on. Let's talk about the prevalence of these dysfunctions. The stress urinary incontinence is prevalent in 32% of primiparous women. Primiparous women, who's the woman who had one delivery on one childbirth only. And the urge incontinence is common in 30% of postpartum women. Having stress incontinence at 3 months postpartum, that will increase the risk of recurrent incontinence during the 5 years later by 92%. So the postpartum incontinence in the short term during the first 3 months in the postpartum phase, it's a strong predictor for the long-term recurrent complaint of the incontinence. Also, the sphincter laceration, it means the tear, the one happened in the perineal area and could extend it to the posterior part, backward to the sphincter. It increased the sexual pain after delivery by 270%. Prevalence of urinary incontinence internationally, based on a systematic review of many population from different countries, it was ranged from 25 to 45%. In a cross-sectional study at Jeddah, it represented 41% to 4%, and at Riyadh, it represented 29%. And also the prevalence of diastasis of rectus abdominis after giving birth is very high. It might affect 50% of women postpartum. And sometimes the problem doesn't resolve after 8 weeks from itself, the diastasis. Sometimes it needs and it requires interventional program, which is Abdomino-pelvic training program, assist in recovery, and it could last up to 6 months. Also, in a British study, they reported that women with one childbirth or one delivery are 4 times more likely to develop pelvic organ prolapse when they are compared to a nulliparous woman. And يعني نقدر نحسبها had the women with 2 children were 8 times more likely of having this prolapse. What's the impact or effect of these dysfunctions on the quality of life and how it could affect the self-esteem? In a cross-sectional study conducted at Jeddah city in Saudi Arabia, the women who complained from urinary incontinence, they reported that they had negative impact of this condition on their quality of life, and it lowered their self-esteem. 33.7% were unable to pray at the time. And 29.9% of them withdrew from social activities, from gathering with their families, with their friends, with their colleagues, and 17.8% reported that this incontinence interfered with their sexual life and affected on their relation with their partner and their marriage life. There are many factors increasing the severity and duration of the postpartum dysfunctions. The patient intrinsic collagen support. The collagen support, it depends on many factors. The genetic factors, something irreversible. Like some factors could be modified and could be changed, which is the lifestyle, which is the nutrients. The amount of nutrients which support the rejuvenation of the soft tissue, which improve the quality of the collagen and improve the soft tissue quality. All the lifestyle factors should be reviewed to improve the collagen support. Also, the size of the infant. Once the infant size above the average, which is the 3.5 to 3.6 or 8, it means that might increase the risk of having severe and lasting longer postpartum dysfunctions. Also, the maternal age, the number of deliveries, the grand multiparity, which is when they are having 5 childbirth and above, that will increase the severity and duration of having these dysfunctions. The route of delivery, when it's operated vaginal delivery or complicated vaginal delivery with using the forceps, with using the vacuum, with any surgical intervention or instruments in the vaginal delivery. As well, when the second stage of the labor is prolonged more than usual, which is the push stage. Also, the degree of perineal trauma, it could affect strongly on the prognosis of the postpartum dysfunctions. So, a lot of studies, it's supporting that it's better to tear, which is the perineal tear or perineal laceration, than to be cut, which is the episiotomy, when the obstetrician cutting the perineal tissue laterally to widening vaginal hiatus to allow the labor or delivery to be easier. A lot of studies reported that women who deliver with a spontaneous laceration report less pain during intercourse than women who undergo episiotomy because of the cutting. When the normal laceration or tear happen, it happened between the tissue cells. So it's easier to be healed or to recover because the cells itself is intact. But when the doctor cut during the episiotomy, they are cutting the cell itself in the middle of the cell, and when they are suturing this cut, this suture it will not heal normally as a normal tissue healed. It might cause some adhesion, it might cause some scar tissue, that will affect on the incidence and the prognosis of having pelvic floor dysfunction. So how can we create efficient pelvic floor rehabilitation program? So how can we create efficient pelvic floor function? how can we maintain it? By a lot of daily movement. Once when we are keep moving and we are active, that it means that we keep our muscle functioning and strong enough. And also by correct optimal training and good movement habits to optimize the weight distribution and the co-contraction between the abdomen, the diaphragm, and the pelvic floor as well. And if there is any dysfunction, the proper management for this dysfunction, because a lot of women, they have lack of knowledge regarding their postpartum health or pelvic health or abdominal muscle health as well. They may ignore these symptoms, these complaints. Some of them, a lot of studies reported that many women think that these problems is common with multiparity and frequent number of childbirth, and it will resolve by itself. So that's not true. It needs to be resolved properly. So incorporating the pelvic floor and abdominal and diaphragm in different sport and activities is the key to manage the postpartum ladies properly. So we have to ask, when we observe the postpartum ladies doing a certain movement or certain exercise, even when she go to the gym for workout, we have to ask about, do they have a stiff thoracic spine inhibiting them from freely moving their diaphragm in the breathing? So if the thoracic spine still stiff after delivery, and we said earlier, and the thoracic mobility will be restricted during pregnancy. If this is still it will, if this will continue after delivery and in the postpartum phases or stages, that means that the woman will not breathe freely and smoothly, and she will not be able to contract and descend that diaphragm itself. Also, when women try to do some exercises in the postpartum, usually in working out and especially in postpartum phases, they are holding their breath during high level of exertion or high level of effort, like doing some, let's say, core training, trying to raise their legs up while they are activating their core muscles. Do they hold their breath? And also, do they exaggerating the lumbar curvature to maintain the lumbopelvic stability, trying to, if there is, let's say, a weak and a floppy abdominal wall, and they are trying to increase and generate the intra-abdominal pressure, but they cannot activate their abdominal muscle properly, they will not be able to maintain the lumbopelvic stability, and that will not give will not give them the power to perform the exercises properly. So they are trying to compensate by exaggerating and activating the lumbar paraspinal muscle, and that will increase the lumbar lordosis curvature to maintain this stability and help them to counteract or compensate the decrease in the abdominal muscle strength or the intra-abdominal pressure. So the postpartum level of fitness, it depends on what they are doing and how they are doing it and how their body respond for what they are doing. When we are training their core, we have to make sure when they are doing any type of exercise, especially when they are progressing and doing graded core activation, and even sometimes in pelvic floor training, we have to make sure that they are breathing properly, the breathing maintaining the continuous breathing level, and the breathing should be accompanied with the exercise, and it should be in harmony and with the flow of the exercise. And also we have to make sure that they are not substituting or compensating with other body parts, and we have to teach them properly to do it, and we have to explain it to them properly so they can keep monitoring themselves when they are going to the gym, when they are training with a personal trainer, or even when they are training in front of TV at home. We have to highlight these things. And the third one is their body is moving freely. The spine, the thoracic, the lumbar, the hip, is it moving freely? And allow them to do the movement without like bracing themselves or holding themselves or substituting by using other body parts. But this is very important. So paying attention to what exercises you do. If you have very weak pelvic floor muscle, or if you have any signs of diastasis rectus abdominis, it's not allowed to start doing the crunches and the sit-ups and the planks and the oblique twist in the postpartum, even after 2 or 3 months in the, from the delivery or from the childbirth. You have to we have to explain it for them properly, that the ladies, the women, they have to so we have to make sure that we explain it to the ladies in postpartum properly. We can explain for them how to use the effort outcome measure. We all know the Borg scale of perceived exertion. We can explain for them how they can use it. So they have to know that they keep their fitness level and endurance level and effort level until 14 maybe or 15, from light to somewhat hard, but they don't want them to reach to a very hard level because we want them to go through graded exercise level. And they have to calculate their heart rate as well to be in the moderate level of or moderate intensity level, the exercise and postpartum phase. Also, we have to make sure to explain for them and to paying attention to what activities bringing on their symptoms. Some ladies may come to you in the clinic complaining from only low back pain, but when you're taking her history, maybe she will report that she gave a delivery within 3 months or less or more. So you have to pay attention to what activities bring her symptoms, the low back pain, and you have to ask her about the other symptoms related or could symptoms could be related to abdominal and pelvic dysfunctions. If she is passing urine or gas involuntary during running or during doing her physical activities. If she is on her feet all day, does she feel any heaviness or bulging in her vagina? That could be reported as a pelvic organ prolapse. Also, when she is doing some exercises, going to the gym with the deadlift, is that weight, when she is lifting this weight, does that make her feel like something is bulging out of her vagina, or she cannot controlling her urine or gas from coming out involuntary? So we have to make sure to highlight these things, because when any woman in the postpartum, or even during her different life stages, if she has one of these symptoms and you are giving her any type of exercises, if her pelvic floor and core muscle is not strong enough, you might aggravate her pelvic floor dysfunctions. The incontinence might increase if you are giving her any exercise with pressing, increasing the intra-abdominal pressure and pressing her pelvic floor in the downward force or downward descent more and more. And also, if you are not keeping your eye on her breathing rhythm, the breathing or diaphragm movement with the exercise or the certain movement you are giving it to her, with the pelvic floor contraction, with the abdominal bracing, if you are not keeping your eye on these things, the harmony and the flow of doing these exercises, maybe the exercise, it will be harmful for her, and maybe she will do a lot of compensation, and she's trying to do adaptation with a wrong movement or wrong body position. This is my email. If you have any question, or if you have any concern about the lecture, if you want to get further details, please feel free to contact me on this email, and I will answer you on each question. And thank you again, and I wish you are all doing fine, and thank you.